Our last speaker for this session is Dr. Suleiman Khan, who is currently a consultant rheumatologist at Kulsoom International Hospital, Islamabad, and Afridi Medical Complex, Peshawar. I'd like to welcome Dr. Suleiman Khan onto the stage to speak on dissecting recent vasculitis guidelines in a local perspective.
Assalamu alaikum, everyone. Thank you very much, PSR, for giving me this opportunity to be here. It's a great pleasure to be in Lahore once again today. I was given this talk to discuss about the dissecting some guidelines, and I said, well, I'm not going to put dissection on my slide because I'm not a surgeon, and as Professor Axford rightly said that, keep away from surgeons and orthopedic surgeons in particular. Anyway, this was a patient that I had seen in Belfast City Hospital, and the lady, a 78-year-old lady who had presented with generally sort of unwell, poor appetite, raised inflammatory markers, and for the raised inflammatory markers, she was referred to rheumatology for obvious reasons. And we did a lot of tests. She was admitted under the medics, but nothing was sort of conclusive out of so many investigations. And finally, we got a PET CT, and that proved to be a lot of dye uptake at the aorta, at the subclavians, femorals, and everywhere really, in keeping with giant cell arteritis. And then she was treated well. So the point to highlight is that these conditions can present in a variety of ways and not necessarily sort of classical vasculitic rashes that you will come across, obviously depending upon the type of vasculitis. But just to touch base in regard to vasculitis, the first thing that we need to ask ourselves is it really vasculitis? Because you will come across a lot of mimics, as Dr. Latif earlier on mentioned about the lupus mimics. So likewise, you can have vasculitis mimics as well. And of course, having sort of an effect on the blood vessels, stenosis, occlusion, aneurysms, it can affect any organ system, and it can be life-threatening and organ-threatening at the same time as well. And of course, you'll be doing a lot of these tests. I'm not going to read the entire slides, but just to give you a basic idea about vasculitis. But at the same time, when we are dealing with these patients, we need to be aware of certain conditions, for example, malignancy, for example, other sort of rheumatic conditions like systemic sclerosis. And earlier on, there was one case presented, and there were a lot of imputations, and I agree that there was this discussion that we need to have antiphospholipid screen for these patients as well, because in antiphospholipid, obviously, you know that the treatment is anticoagulation rather than immunosuppression. And of course, the presentation can be in a variety of different ways, mononeuritis multiplex, some asymmetric polyneuropathies, and so on. When we talk about vasculitis in this country, I find it difficult on different levels. For example, if I compare my practice to what I do here, I usually have come across poor sort of access to diagnostics, to imaging, to immunology, to histopathology, whereas in the NHS or in the West or the US, you have got good access to these modalities, and that really helps. Then the MDTs are rather poor. I know that some people have started MDTs in their departments, but it's not that robust, and obviously we need to work on that. Centers of excellence for vasculitis are rather lacking, although in some centers they have started working on vasculitis to sort of develop their services in that sense. But there are almost none vasculitis research or fellowships in any department after the FCPS in rheumatology. So that's what we sort of need to work on. But the good thing is that in comparison to the West, we have comparable sort of medications available. And I'll give you the list of those medications: glucocorticoids, cyclophosphamide, TNFs, tocilizumab, mycophenolate, methotrexate, and so on, azathioprine, rituximab, plasma exchange, IVIGs. These are all available over here. And I therefore thought that we need to thank our American friends and the ACR for putting together all these guidelines for us. So I probably will be dissecting a little bit of those ACR vasculitis guidelines about these conditions. When we talk about giant cell arteritis, obviously you are all aware that the high-dose oral glucocorticoids are preferred initially in comparison to pulse glucocorticoids. But of course, if the patient has visual loss, then IV pulse glucocorticoids over high-dose steroids is preferred. Daily dosing is preferred. So these lines have been taken from the ACR guidelines. So that's why I have sort of highlighted a few things, and I'll try to cover most of them, although I have avoided some of the slides due to time limitation. Initiating treatment, high-dose oral glucocorticoids or moderate-dose oral corticoids is preferred. Use of glucocorticoids with tocilizumab is preferred over glucocorticoid alone. Now, if your patient has got active extracranial large vessel involvement with oral glucocorticoids combined with a non-glucocorticoid immunosuppressive agent or glucocorticoid alone, so a combination is rather preferred in comparison to steroid alone. The optimal duration of therapy, however, is variable, and it is rather difficult to say that, whether you need to treat it for 6 months, a year, or 18 months, but it really depends on your patient, and individualized, personalized sort of approach will be something that you will be practicing, I'm sure. If your patient is newly diagnosed, the ACR conditionally recommended against the use of any statins. However, it does support the idea of adding aspirin. So commonly, if you think that you are adding statin, I think probably there is not much sort of support in that sort of idea, but aspirin is okay to add. GCA who experience disease relapse while receiving moderate to high dose glucocorticoids, they conditionally recommend adding a non-glucocorticoid immunosuppressive therapy. If there is cranial ischemia, then adding a non-glucocorticoid immunosuppressive agent and increasing the dose of glucocorticoid or increasing the dose of steroid alone. So obviously, if your patient has got active symptoms and there is evidence that the GCA is active, then steroid alone is not the way forward. You will be giving a combination. Tocilizumab is one of those biologics that is recommended. GCA who experience disease relapse with symptoms of cranial ischemia while receiving glucocorticoid, they conditionally recommend adding tocilizumab and increasing the dose of glucocorticoid or adding methotrexate. So methotrexate after glucocorticoid is not advocated. You will have to go for tocilizumab. In Takayasu, obviously, having active inflammation in the blood vessels, you will be using high-dose oral steroids in comparison to IV pulse steroids, although this is rather debatable, and in some cases, you will be using pulses, but it's really dependent upon the nature of the patient's condition. Patients with newly active severe Takayasu initiating treatment with high-dose glucocorticoid over low dose is supported by the ACR. Patients with active Takayasu, use of other non-glucocorticoid immunosuppressive therapy over tocilizumab as initial therapy. Now, after steroids, you will be thinking about anti-TNF rather than tocilizumab. This is about Takayasu. Although I must say, and I must admit that I treated one patient with tocilizumab and she responded well. So according to the guidelines, the first thing after the steroids, if we want to really consider biologic, that will be TNF. They conditionally recommend clinical observation without escalation of immunosuppressive therapy in patients with apparent clinical remission, but with an increase in level of inflammatory markers. So that means that you do not treat ESR or CRP, you treat your patient. And if there is a mild or even some rise in inflammatory markers, that should not trigger you off to sort of increase the steroids or escalate the treatment to biologic. In polyarthritis nodosa, the ACR recommends that these patients need to have abdominal vascular imaging to aid in establishing a diagnosis and determining the extent. And then they can have serial follow-up abdominal vascular imaging as well. You will be thinking about deep skin biopsy specimens, combined nerve muscle biopsies to reach to your conclusion and confirmation of your diagnosis. And this thing again, like in clinical practice, instead of doing serial tests for example, in ANCA-vasculitis, I'll come to that, there is a slide on that as well. Instead of repeating all those autoantibodies, or instead of requesting EMGs or NCS time and again, you will be examining your patient. So there is no alternative to examining these patients properly from time to time to see if there is any deterioration in their clinical condition. So treatment of newly diagnosed polyarthritis nodosa, IV pulse glucocorticoids, but here is the difference. So after steroids, it is cyclophosphamide in polyarthritis nodosa. In Takayasu, it was anti-TNF. In giant cell arthritis, it was tocilizumab. So these are the things that we need to keep in mind when we are treating these patients. Patients who are unable to tolerate cyclophosphamide, treating with other non-glucocorticoid immunosuppressive agents, and glucocorticoids or glucocorticoids alone is preferred or recommended. Newly diagnosed active non-severe polyarthritis nodosa, recommend treating with non-glucocorticoid immunosuppressive agents and glucocorticoids, or so basically a combination of glucocorticoids and further immunosuppression is recommended instead of glucocorticoid alone. Plasmapheresis, newly diagnosed active severe polyarthritis nodosa, against using plasmapheresis combined with cyclophosphamide and glucocorticoid, or cyclophosphamide and glucocorticoid alone. So basically, plasmapheresis, historically, which was thought to be very useful, is probably going down the list of those management lines. You will be thinking about discontinuation of non-glucocorticoid immunosuppressive agents after 18 months or continued indefinite treatment. So the treatment should not be indefinite. If you're given them cyclophosphamide, you certainly need to think about switching to other non-glucocorticoid immunosuppressives and so on. And again, the duration of therapy, it is not well established. In refractory cases, switching to non-glucocorticoid immunosuppressive agent to cyclophosphamide or increasing steroid alone is advocated. And then if your patient has got cyclophosphamide, you'll be thinking to switch them over to other non-glucocorticoid immunosuppressive medications rather than continuing cyclophosphamide. This one now, the important one. Okay, so obviously we use a lot of steroids, but if your patient has active severe granulomatosis with polyangiitis or microscopic polyangiitis, the ACR conditionally recommend treatment with rituximab or cyclophosphamide. So the first biologic that you should be thinking about would be rituximab for remission induction. In patients with active glomerulonephritis, the ACR conditionally recommends against the routine addition of plasma exchange. So again, going down the bottom of the list for the management of vasculitides. Induction therapy in severe cases with active severe GPA or MPA with alveolar hemorrhage, the ACR conditionally recommends against adding plasma exchange to remission induction. So again, there is time and again mention of plasma exchange, I'm afraid. In patients with active severe GPA or microscopic polyangiitis, the ACR conditionally recommends a reduced dose or standard dose of glucocorticoid. And then methotrexate is once again sort of the most respectable amongst these conventional oral DMARDs. So if your patient has active non-severe GPA, the recommendation is that you will be starting them on methotrexate rather than cyclophosphamide. And methotrexate and glucocorticoids are preferred in comparison to glucocorticoid alone. Methotrexate and glucocorticoid are preferred or as a thiopurine plus glucocorticoid, or mycophenolate for that matter. So mycophenolate is bottom of the list. Not much sort of data for that or recommendation for mycophenolate. And likewise, the trimethoprim sulfamethoxazole sort of combination with glucocorticoid is not the ideal one. Sometimes we do that for PCP prophylaxis, but methotrexate will be your line of action when you're dealing with these patients. In severe GPA or MPA, who have entered remission after treatment with cyclophosphamide or rituximab, the ACR conditionally recommends treatment with rituximab or methotrexate or azathioprine. So that means that if your patient has become well with cyclophosphamide or rituximab, instead of putting them on methotrexate or azathioprine, you should perhaps continue rituximab. Now, if your patient has got better with rituximab, instead of doing their ANCA titers or CD19 B cell counts every now and again to sort of guide you in terms of further treatment, you should rather plan scheduled redosing with rituximab. And that is something that is practiced, and that is what the ACR is now recommending. In patients with severe GPA or MPA who received remission after treatment with cyclophosphamide or rituximab, the ACR conditionally recommends treatment with methotrexate or azathioprine or mycophenolate. So again, mycophenolate is of not much use here, I'm afraid. In patients with severe GPA MPA who entered remission after treatment with cyclo or rituximab, there is conditional recommendation that we need to treat these patients with methotrexate or azathioprine or leflunomide. So leflunomide is out of the box, mycophenolate is out of the box, plasmapheresis is almost out of the box, and you are sort of dealing a lot with glucocorticoids, methotrexate, rituximab, cyclophosphamide, and then there will come this role of IVIGs as well. If your patient with GPA or MPA is on remission maintenance therapy with rituximab, who have hypogammaglobulinemia and recurrent severe infections, then in that case, the IVIGs are perhaps a better option. And if they have had a relapsed with severe disease manifestation and are not on rituximab, then certainly you will be considering rituximab. In patients with GPA, MPA with relapse while on rituximab, the conditional recommendation is switching rituximab to cyclophosphamide. So cyclophosphamide is coming after rituximab in that order. And if your patient is refractory with severe GPA, MPA after treatment with rituximab or cyclophosphamide for remission induction, there is conditional recommendation that treatment with other therapy over combining the two therapies. So sometimes people feel that, we need to combine the two, but now ACR is suggesting that we probably need to think about alternative immunosuppression rather than giving a trial with the same medications again. In patients with GPA, MPA refractory to remission induction, immunoglobulins, as we discussed earlier on. And if a patient has got nasal septal defect, then certainly you can refer them for reconstructive surgery, if desired, obviously, by the patient. If your patient has got subglottic or endobronchial tissue stenosis, then the preference is for immunosuppression rather than surgery. Sometimes we feel that, okay, refer to ENT to sort of dilate those areas, those scars, but perhaps that is not the best thing to do. If there is a pseudotumor or masses, again, the recommendation is more inclined towards immunosuppression rather than surgical removal of the masses. Sometimes you'll come across retroorbital sort of masses, and and in those cases, those patients really respond well. And if you do a serial sort of MRIs, then there is regression of the tumors after treatment with rituximab. I've seen that. In patients with GPA, MPA, there's conditional recommendation against the dosing of immunosuppression based on ANCA titers. Please do not do this. There's no need to sort of do serial ANCA from time to time, serial anti-double stranded DNA. I'm not sure what people thought on the other autoantibodies is that, but it is more for diagnostic purpose rather than for disease activity purpose. And if your patient is receiving cyclophosphamide or rituximab, there is conditional recommendation that prophylaxis for PCP should be given. If your patient is in remission and has chronic kidney disease stage 5, then they probably should be evaluated for transplantation. And if your patient is unable to receive other immunomodulatory therapies, then obviously your final thing to consider would be IVIGs. Thank you so much. So basically, to improve our sort of practice here in this country, there should be more sort of MDT coordinated sort of efforts. We need to obviously consider the guidelines so that we can use these medications judiciously and tailor the treatment according to the personal sort of needs of the patient. This is what I call personalized medicine in rheumatology that we need to practice. Thank you so much.
Thank you so much, Dr. Suleiman Khan.
The floor is now open for questions. You may hand your questions written on question cards to a member of the hall committee.
So the first question we have is for Dr. Beena. The question is, we see a lot of eye patients, panuritis, stuck for anti-TNF after azathioprine. What's your experience with MTX and cyclophosphamide?
So yes, the eye disease could be very challenging in Behçet's disease. I haven't used methotrexate because there's no recommendation, but I've used azathioprine in combination with monoclonal antibodies. It works well. Same is for other organ disease, severe refractory other organ disease. Cyclophosphamide I had used once when I was back home in UK, because I don't use cyclophosphamide now because most of the patients, they are younger and you are concerned about their fertility. So I think if there's no availability and it's a site-threatening complication, then if you've got nothing else, it's fine, it's justifiable to use cyclophosphamide.
Thank you, Beena, for your excellent talk. So we actually are presenting an abstract. One of our fellows have co-worked with me on autoimmune uveitis seen in rheumatology practice. So we have a case series of 34 patients. 26% of them actually had Behçet's. And out of these 26, 24 actually had panuveitis. And we treated them with methotrexate and a combination of adalimumab. And 87% of them actually went into remission. So it is very promising. So we have now monoclonal antibodies available. So they are available on demand. They are unfortunately not widely available, still very expensive. But we were able to have some kind of a liaison for which I through Arthritis Care Foundation, we were getting it at a very subsidized rate, and we are glad to share our experience and do visit our the e-abstract book and go, and it's really encouraging that young fellows are coming up with these new data. Thank you.
I think one of the plays for methotrexate is if you want to use them with infliximab or other monoclonal antibodies is to prevent the hacker response where you might lose the efficacy because of the neutralizing antibody formation in these patients.
Excellent talk as ever, Beena. Over the years, I've become quite a fan of colchicine. I don't know what Terry thinks about colchicine as long-term maintenance in gout, but is colchicine central to your treatment for patients with Behçet's?
So the EULAR recommendations are for erythema nodosum. But although the study says might not work for, but I think that my experience being colchicine works fantastically for minor ulcers, oral ulcers in particular. So I use it a lot for my patients, colchicine. I mean, sometimes there are patients who might come only for with oral ulceration, nothing else, and you've excluded everything else. And it's the right person from the Gulf area, because I'm practicing in Gulf now in Dubai, so we see a lot of patients. And the mouth ulcers, they fantastically work very well with colchicine. That's our experience, yes.
So my name is Tariq Iqbal. I am a consultant rheumatologist at Afridi Medical Center. My colleague, Dr. Khan, also did a nice presentation. So I have a question for each of the presenter. So the first question is for Dr. Hamid in regards to Behçet's disease. So I will share my experience. I've seen a few cases over my career, of course. I practiced in Canada and now here. So I've not seen a case here, but the cases I've seen in America, I will describe one case, and I just want to get an input if Dr. Hamid has any input or experience with these recent JAK inhibitors. So my case was a young lady with orogenital ulcerations and arthralgias, and also eye involvement and skin lesions. So we did start, as Dr. Axford said, with colchicine, and then she did respond, but not completely, so we moved on to steroids, and then added methotrexate. She did very nicely, but then she started developing perianal fistulas. And although the orogenital ulcers had improved, but that kept progressing, and then she had bowel involvement. Now, as you were saying, segmental versus focal. So we did involve gastroenterology, and the differential was whether it could be Crohn's. So they were not very sure, and there were no other features. So because of the recurrent oral and genital ulcers, the diagnosis, we geared more to Behçet's. So ultimately, anti-TNFs were tried, but it became a recalcitrant disease. Now, at that time, JAK inhibitors were new, so we didn't try. But I just wanted to get your input if you have any experience, or is there any data on tofacitinib?
So I haven't come across any data. There's an anecdotal experience like yours. People have presented some cases. But generally speaking, infliximab works very well. I have a patient, European patient, who had a severe intestinal Behçet's. She has been on azathioprine, has been on colchicine, but she didn't respond. And she had somebody gave her sulfasalazine as well. But when I started on infliximab, I kept her on azathioprine as well. She responded very well. I'm aware that JAK's now been approved in inflammatory bowel disease. People are using them with a good experience, but I haven't had any experience with, or haven't any of my colleagues have used it so far.
Okay, great, thanks. So can I ask my second question while I'm standing from Dr. Axford? So you had a nice presentation on mimics of PMR, and yeah, I would agree. I mean, they can be sometime overlapping. My question was about your 60-year-old lady who you said had Takayasu's. And considering she had significant aortitis on imaging, could it have been, well, large cell, could it have been GCA aortitis, or for that matter, there is data about IgG4 related disease. So did you thought about that?
Yes, it could have been anything. These are just labels, aren't they? I think my label was the most appropriate one, and she's responded very well to treatment with corticosteroids alone. But,
right.
Yeah.
Okay. And Suleiman, nice presentation. So my question was about the plasmapheresis, and you mentioned cyclophosphamide in PAN. So of course, I mean, our experience with non-severe disease very good with methotrexate and azathioprine, and of course steroids, which is the first line. My question was about, I don't have much experience with plasmapheresis, but can you explain your experience, or how would you use plasmapheresis and cyclophosphamide? Is it sequential, or you space it, or is it combined?
To be honest, I haven't really used a lot of plasmapheresis in these patients. It's mostly sort of immunosuppression with either rituximab or cyclophosphamide. But if at all somebody is sort of thinking about it, the guidelines is now sort of going against it. So first of all, cost is an issue as well, and then the availability of plasmapheresis in, different hospitals is an issue as well. It's not sort of readily available everywhere as well. So either it's, the availability, either it's the cost, and then, it is coming at the bottom of the list as well, so I haven't really used it a lot. Thank you.
Polyarteritis nodosa. If the patient is having hepatitis B concomitantly and has polyarteritis nodosa, then still there is place for plasmapheresis initially, followed by immunosuppressive therapy. So
Yeah, possibly.
Because the Western, they're totally now immunized for hepatitis B, they won't encourage this, but still we are having hepatitis B prevalent in our part of the world. So in our patients, Hep B associated polyarteritis nodosa, first plasmapheresis, then followed by immunosuppression.
Right. Okay. Thank you.
Thank you very much, Salman. We have been seeing ANCA-associated vasculitis and patients presenting with alveolar hemorrhage. And we have been taught and we have been doing for quite a long time plasma exchange. And we have seen a very good result as well. In our part of the world, patient presenting with alveolar hemorrhage and going for an IV immunoglobulin says, it's very expensive. So what is in your experience? Have you been using plasma exchange for alveolar hemorrhage?
I think I agree that there might be some improvement, but at the same time, it's not just the plasmapheresis people sort of, give to these patients. At the same time, they are given steroids. At the same time, they are immunosuppressed as well. It's as if you treat inflammatory arthritis with tramadol and start them on some hydroxychloroquine as well, and after some time you see some improvement, whether it's the tramadol helping with the pain or whether it's the hydroxychloroquine improving the inflammation. So it's a sort of vague, sort of grayish area, so to say, but it may have improved your patient in those conditions, in those situations, probably.
Thank you.
So we have few questions.
A question for my colleagues here. As you mature in rheumatology, you look for simple solutions, and it's intriguing coming to Pakistan to talk about plasmapheresis. But Dr. Khan was very brave in putting up a slide showing all the things that Pakistan didn't do very well. But I would disagree with one thing you put up, and that was MDTs. And I think one of the things that you've learned and you've taught us to do is communicate very well. And when Nigat and I were having a tough time with our meetings in 2020, Zoom lectures really took off in Pakistan and have left London behind. And I was going to ask Sami here about how you survive in Iraq. And WhatsApp groups for MDTs are something really taking off in London. And I hope you will participate in them, because talking is really central to this business. Maybe Sami can comment about life in Iraq.
So we have few questions from the audience. So there is a question by Dr. Hassan, Registrar in Medicine, to Dr. Beena on role and indication of warfarin in venous thrombosis in Behçets.
Thank you. So like I said in my slides, that the problem with the anticoagulation is that if somebody's got underlying aneurysms, they can burst and cause bleeding. So unless you have performed the scans to look for those aneurysms, you probably won't anticoagulate these patients. For instance, if somebody presents with deep venous thrombosis below knee, I would not anticoagulate them. I just give them the glucocorticoids and immunosuppressive therapy. But yes, it could be challenging in terms of arterial thrombosis, where you probably would think more of, but then you have to screen your patients in detail before you give them anticoagulation. That's what I think is reasonable.
Thank you. So there is one question for Dr. John Ashford. So by Dr. Saadat, he's a rheumatologist. If PMR is, if the predominant symptoms are like PMR in a suspected GCA situation, so do you really go for tocilizumab in such patients as a steroid sparing? So.
question is, Ahmed, do I go for rituximab?
Tocilizumab.
If only I could use tocilizumab in London. It's £2,000 a shot. It's really difficult to actually use. I should think it would be quite good fun to do. Quite frankly, PMR and giant cell arteritis, I do exceptionally well with glucocorticoids on their own. They are two of the few diseases that are actually cured by corticosteroids, and patients can expect to be off medication within 18 months or so. So no experience with tocilizumab, I'm afraid.
I think so. Now we can request our worthy chairpersons to have their comments. We can start with Dr. Saliha Ishaq.
Assalamu alaikum, everybody. What a wonderful presentations. Thank you, Dr. Khan, Dr. Hamid, and Dr. Axford. Very valuable points were raised by our questionnaires, people who asked all the questions. I just have few things that I just wanted to add. There was a lot of questions about plasmapheresis in GPA. The reason we don't do plasmapheresis because rituximab is generally given initially, and if you do plasmapheresis, it takes rituximab out of your blood. So that is one of the reasons plasmapheresis is not given after rituximab. Then there was a question about hemorrhagic lung disease. So I have seen when it is hemorrhagic lung disease, normally cyclophosphamide is the only one time when it is preferred, because that is the time when acute intervention is needed and people do give cytoxin. Otherwise in GPA, rituximab still is taking number one. And I would highly agree with Dr. Bina that she said about warfarin. So Dr. Mahmood Riaz and I work in Aachen, and we have a bunch of patients who come with pulmonary embolism and we cannot find anything. But we got lucky that in Liaquat National, we have HLA-B51 antigen tests. So when we did those tests, they were Behçet's, we confirmed Behçet's. And the query was like, now what to do with them, because they were aneurysms and plus they could also bleed. But then we dig down, in fact, Dr. Mahmood Riaz helped me dig down the papers, and we had to give them warfarin because they were clotting in small places, and this was venous thrombosis. And we were scared that now arterial thrombosis can come too. So after digging down, we realized if somebody has thrombosis, and if it is recurrent, you have to give them immunosuppression and warfarin. I hope, Dr. Bina, would you agree with that? So just because we have seen a few cases, I wanted to share it with you. And then I would like to thank all of you for coming to Pakistan. This is a team coming all from abroad, and hope we can show you a good time in Lahore. I'll just hand over the mic.
Thank you so much. I'm very, very grateful to Dr. Nigat Mir, Dr. Ahmed, Dr. Samara, and my very own Dr. Bilal for inviting me today to witness this wonderful, wonderful session. I'll start with what Dr. John Oxford said. सर आपने लाहौर आने का शुक्रिया कहा, मांगा, हम आपको लाहौर आपने हमें बुलाने का शुक्रिया कहा, हम आपको आने का शुक्रिया कहते हैं. So if you understand what I mean, now this is a quiz. So I quizzed you back. This means that when you said thanks for us inviting you to Lahore, we are saying thanks to you to coming to Lahore. So I mean, it's the other way around. I really loved your point when you said that our rheumatology patients are friends for life. Yeah, they are. I am an internist, a general physician, but I've had this privilege of working indirectly with Professor Nigat Mir in a way that I've been associated with two of her students at two of the universities where I've worked, Dr. Yasir Imran and Dr. Bilal. And I have the privilege to, sort of be one of the coordinators for the rheumatology clinics. So yeah, these patients are friends of life. And when you talked about the bell ringing, I remembered I'm from Sacred Heart Convent School, and it's a Christian school. And we used to have that specific church bell at break time and at home time and when the school ended. And as our sister who used to, ring the bell grew older, the ring of the bell changed. So I could very well relate to that specific patient, I think the first one whom you talked about, the change in when she talked about the change in the ringing of the bell. You talked about steroid trial. I don't know, but I wonder what Professor Nigat Mir and the rest of the rheumatologists here would say. But as an internist, I would say that they've already had the trial by the time they come to our hospitals in Pakistan. And the trial is by local, people whom we call Hakims. Hakims are sort of, alternative medicine or, local people who are not actually doctors, but people have a lot of trust in them because they belong to the area and they have direct, way of communicating with them. And they usually have given them steroids by the time they come to us. And one point is that they rather prefer going to the Hakims than us because we would be, giving them a list of investigations and which would cost them so much. While the Hakim would give them a puri, a puri is a little, piece of paper in which they put the steroid or make a powder of them. We call that safoof, the powder. And they have already taken them and they are feeling better by the time they are referred to us or the rheumatologists. And thank you so much for your wonderful talk. Dr. Beena, your talk was absolutely amazing. You talked about 25 years of this conference and 75 years of Washe disease and 75 years of Pakistan. We can relate all of this together. Coming to Pakistan, this was actually a question which I will ask Dr. Nigat Mir. I know this is not the point to ask questions, but I don't know, Professor Nigat, if you could comment on how much the prevalence of Bashe disease in Pakistan is. Because we should carry a high index of suspicion. As Dr. Beena labeled the lecture hidden disease, this is very much hidden because in Pakistan, because of conservative society and all, people don't come up with the complaints of especially genital ulcers.
Thank you so much. I cannot forget one of my patients who I saw for the first time, and she was totally blind. She was like a 30-year-old woman who had first presented to an ophthalmologist, and the only question which needed to be asked was whether she had ulcers. So we see a lot of Behçets, difficult Behçets. We don't have the prevalence studies, unfortunately, because all of us, Abed, Sumaira, Saira, Bilal, and all the colleagues from other cities, we all see lots of Behçets and challenging Behçets. But I think it's underdiagnosed because they present to various clinics rather than directly coming to the rheumatologist. And you're so very right in saying that they already have taken the Hakim's, parchi, and so it becomes difficult to diagnose also later on when they are on stage. But we see a lot of Behçets.
Exactly, madam, and this is, so we as internists should carry a high index of suspicion. Dr. Suleiman, your lecture was absolutely amazing. You talked about non-fellowship programs. I beg to disagree with you. We are privileged to have Professor Nigat Mir, and day before yesterday, she was at our alma mater, Fatma Jinnah Medical University, and the Vice Chancellor of Fatma Jinnah Medical University labeled her the grandmom of all the rheumatologists, because the next generation is Dr. Sumaira and Ahmed and Bilal, and the rest are the, the children. So I think it has been a great effort from her side that now we have fellowship programs. In Lahore, we have fellowship programs at King Edward Medical University and Fatma Jinnah Medical University. Dr. Oxford talked about the increase in the Zoominars. My question is, during the COVID days, Dr. Oxford, we established a telemedicine department at one of the big universities of Pakistan. And I can see Dr. Tuba and Dr. Samara sitting in the hall. They were very much a part of following up the rheumatology patients on telemedicine. And very religiously, they would be doing that. So when Dr. Suleiman talked about regular examinations and regular follow-up, I would just like to know what was your experience regarding telemedicine, especially during COVID days in rheumatology in London.
The short answer is that it was better than nothing. I think the two take-home things are, one, it is very time-consuming, and administration was vast for some reason. So I would spend a whole day sorting out 10 patients only. After you had had a Zoom for more than, say, 3 consultations, you started to miss things, and the examination was very, very important. So that was my limit, and then I would try and get the patient back in for a proper examination. The observation as well, I don't know whether you do this here, but there's a lot of GP criticism going around the UK at the moment, and some of it is justified, but our family practitioners have telephone conversations, and I find that totally impossible. You know, one can have a follow-up over a few minutes with a patient about how well they're doing with their certain drugs, but an initial consultation by telephone is impossible. So you've actually got to see the patient. That's important. Have I answered the question?
Yeah, there's absolutely, I totally agree with you. So thank you so much, and thank you for giving this opportunity. Thank you.
Professor Abid.
Thank you very much. I'm not going to take much of the time because everyone has taken it. I have 3 weeks of experience of working in rheumatology in Walsgrave Hospital, Coventry, back in 1997. I'm a neurologist, by the way, by profession. So everyone, except her probably, everyone is rheumatologist, but I'm a neurologist by profession. I have experience of managing Behçet disease causing dural thrombosis in Shalimar Hospital. He did well, actually. We gave him the anticoagulants, and they responded well. Unfortunately, we didn't have the facility to look for some aneurysms in the lungs by doing CT angiogram, but me as a neurologist and Dr. Hamdani as a rheumatologist, I don't know, Dr. Hamdani is sitting here or not. So he was the rheumatology chap, and me from neurology, we managed that one. Dr. Bina covered everything. In fact, all the speakers were marvelous, no doubt in that. And by the way, whenever a person comes to us with a weakness, as John said, I always say that we, from the neurology side, we look for the true muscle weakness. It's not the asthenia we're looking at. It's not the locomotor abnormality we're looking at. True muscle weakness, once the patient is having that, that means the patient needs to be evaluated by the neurologist. That's the one, right? And then we go subsequent, because polymyalgia rheumatica is like is a disease seen by the rheumatologist, seen by many people actually, the primary care physicians as well. But as a neurologist, we also see the PMR, and we do give the trial of prednisolone, 7.5 milligram. They respond very well. Dr. Suman was absolutely correct. The culture of MDTs are very lacking in Pakistan, but the COVID-19 has actually taught us that. While doing the conferences through the Zoom, we can do the MDTs while sitting in our offices or anywhere actually. So MDTs should be encouraged, and that will going to help us. And finally, I have honor of working in Turkey actually. So I do not know much of the Turkish language, but the Behçet is rampant in Turkey, and I used to see the neuro-Behçet disease there. And I don't know many of you know about Trishul. It's a Hindi term. Once the Behçet affects the spinal cord, and we do a T2-weighted MRI of the cervical spine, we see like 3 prongs in the posterior side of the spinal cord. We call it the threshold sign for the neurobashe. And by the way, whenever there is small tick below the C, if you read the spelling of a bashe is B-E-C-H-E-T. Once there is a tick below the C becomes sh. So that's a bashe disease. From there, like, the word comes. And the bashe was a Turkish dermatologist, as everyone said. Thank you very much.
Thank you. Professor Sami Salman used to tell us that it is called Behjat disease, I remember. It was named after that. Thank you. Thank you. Now I would request all the chairs to please come for the distribution of the shields, for the shield distribution.
While you are getting together,